Hello. I'd like to welcome everyone to the Parts Source HTM Leadership Series. Today's presentation is the second of our 7-week series that will run through November the 12th. Today's session, Staffing Optimization for Obtaining the Highest ROI for Your Organization, will be presented by Jeremy Cook and is hosted by David Brennan. Before we begin, I'd like to review a few housekeeping items. First, you should have a control panel at the side or bottom of your screen. You can minimize and control this panel. Also, you can submit questions using the question portion of the control panel. We will answer questions at the end of the presentation. If your question is not answered live, we will respond to you individually after the event. All registrants will receive a link to the recording after the webinar. This information will be sent to the email address with which you registered for this event. And now please allow me to introduce Dave Brennan, Senior Vice President and Chief Product Officer at Parts Source. Dave joined Parts Source in 2018 after nearly 20 years with GE Healthcare. During his tenure at GE, Dave held executive roles in various divisions and led the growth and market expansion of aftermarket parts and services. As Chief Product Officer for Parts Source, Brennan leads Parts Source's expanding portfolio of clinical resource management services available to our Parts Source Pro customers and tools for thousands of suppliers that partner with us to support our mutual customers. Now I'll hand it over to you, Dave.
Thanks, Colleen, and thanks everyone for joining us today. For those of you that know us well, you know that Parts Source values our partnerships very dearly. Our partnerships with our clients, with our suppliers of parts, equipment, and service, and with a broad array of HTM leaders across the nation, coast to coast. And the goal of this HTM Leadership Series is to really expand and leverage these partnerships for your benefit, to connect leaders across this community and to discuss topics that we think are near and dear to your hearts and the future of healthcare technology management. It's my goal that you'll get insights into how to strengthen your decision-making, how to improve your planning processes, how to increase your efficiencies, improve quality, drive cost out of your organizations. We think of these as the most pressing challenges across the HTM and healthcare supply chain space today. So one of the most common and constant challenges in this space is, how do I get the most ROI out of my organization? How do I balance all of the different activities that come my way as an HTM leader? How do I weigh my options, make the tough calls with your teams, with your leadership, across your vendor space? How do I maximize my total return? And in 2020, with COVID-19 here in a large way across the nation still, this topic has never been more critical, really, for all of us. So I'm really pleased today to introduce my friend Jeremy Cook, who will be presenting today. Jeremy is the Senior Director of Healthcare Technology Management at Methodist Le Bonheur Healthcare, where he's been for over 24 years. And during his time there, he's held a bunch of different roles, from biomed technician to biomed department supervisor, director of clinical engineering, senior director of technical supply chain. Today, he's got most everything under his wing as clinical engineering, capital asset management, and medical device service contracting. So it's important to tell a little story that early in Jeremy's career, as he was a biomed department supervisor, Methodist came to him and explained that they had cost out ideas brewing. And one of these ideas was the proposed outsourcing of the entire clinical engineering department. Jeremy had other ideas. Jeremy presented an alternative cost reduction plan. He was able to show the math behind substantial cost savings for the health system, and his plan was ultimately approved. He really hasn't stopped or looked back since then. He continues to lead all the insourcing activities, the efficiency initiatives within Methodist, and is continually searching for smarter and smarter alternatives in the space. He routinely saves his organization over $6 million a year in operating costs, and he does it without any kind of shared service contracts. So I'm sure you're going to learn a lot and enjoy his presentation today. We're really pleased to have him with us. And with that, I'll pass it over to you, Jeremy.
Thanks, Dave and Colleen, for that great introduction. As Dave was saying, this presentation is basically how to optimize and obtain the highest ROI for your organization with your existing resources. So first, let me tell you a little bit about our organization. Methodist Le Bonheur Healthcare is a 1.85 billion revenue organization with over 11,000 associates, physicians, employed physicians. We operate close to 1,700 licensed beds. We have a world-renowned solid organ transplant program in the top 10 nationally. In our market, we have a lot of uninsured and underinsured people in the Memphis and North Mississippi and West Memphis area. And that means that we have to be very cognizant of our costs so that we can continue to serve the underserved. And that's one of our mission and vision and values that we share. We have a very consolidated hospital market and payer market, which means we have to be incredibly competitive so we can negotiate well with our insurance providers. We are a 6-hospital system. 5 of those hospitals are in the Shelby County, Tennessee area. It also includes our Le Bonheur Children's Hospital, which is a world-renowned children's hospital, one of the top neuro programs in the country. We trade first place with Boston Children's on a regular basis on volume of neuro cases that we do in partnership with St. Jude. We have many awards, top places to work. Methodist is a very associate-driven empowerment organization, always looking for ways to drive innovation and stuff of that nature. So we'll move into the presentation and we'll talk about today's healthcare environment. You know, as Dave said, today's healthcare technology departments are being pressured to continue to do more with less. I mean, we always are being asked to do that. I don't think that has gone away. I think it's just been more exacerbated with the situation with COVID and other things that have happened over the years. This means that management of these departments needs to ensure that the labor resources that we have, that they produce the greatest value or return on investment for each hour of biomed work performed. So HTM departments, you know, they're typically understaffed or working with open positions. We all have challenges filling open positions these days, especially with a lot of the older generation retiring and moving on and struggling to get new associates or engineers into your organizations. So we also have constantly changing priorities and work responsibilities. As I've said, a lot of people tap clinical engineering departments for all kinds of problem-solving efforts. So from time to time, our priorities change. We all, from time to time, have to rely heavily on third-party and OEM support. So that sometimes becomes a challenge as we look for ways to drive more value and to also reduce costs within our organizations. And of course, the current COVID crisis has really added additional support and processes where we've had to flex up and flex down as we've all maybe have to have furloughed employees and or reduce staff hours, and then trying to figure out how do we maximize what we do with the hours that we still have available to us to utilize to benefit our organizations. And we all are always asked to jump onto committees and projects that our organization feels is of extreme strategic importance, whether that's a growth strategy or an expansion opportunity into other areas. HTM department leaders are always brought into those discussions and asked to participate because we are a lot of times seen as problem solvers. And at the very least, we're seen as a department that understands the technology that may be needed for those strategic initiatives. We've all probably seen a lot of unexpected OEM recalls over the last year or so, with a lot of infusion pump companies having device recalls. Those also require a lot of management by HTM departments. Yes, sometimes the vendor comes in and does that work for you, but it sometimes requires hand-holding of those vendors by the HTM department. And then we all get asked for what I call out-of-scope service requests. Recently, we had one, and it was one that my boss reached out to us and asked us to work on something that was deemed unrepairable by everybody, but was going to cost our organization $1 million to replace, which was our in-house laundry service had a tunnel washer. And we were asked to see if we could do a Hail Mary and fix this device. And luckily we were able to do that. But from time to time, HTM departments are asked to do that out of scope type work. And we want to be able to step up and do those type things as well. So ensuring that we evaluate this is extremely important. So when I went through the effort of evaluating HTM efforts, I typically look at it from the standpoint of activity or labor and the value associated with that activity. And I have some rules that I kind of manage by that I've kind of developed over the years to make sure I kind of set some ground rules for how I look at these perspectives or activities. And the first one is activity doesn't always produce value. So a lot of times HTM departments will just do work because that's what they've always done. But they haven't ever asked themselves the question, what value does this work have? And what is the value? Or does it have value at all? And then the other one is that has to do with the activity is not all activity produces the same value. So you can't say that a PM and a repair produce the same value because that's not always the case. And that's just one example. And then one of my other rules is value is measured in different ways from differing perspectives. Clinicians, they don't always value what's the cost to the bottom line. Sometimes they value, are you making my life better? Are you making me more efficient? Are you making me, are you keeping my equipment up so that I can take care of my patients without undue burden? CFOs, let's face it, they care about the bottom line. How are you producing value to their bottom line, and how does that improve their ability to take on new tasks or expand services or stuff of that nature? And then administrators, they kind of look at a combination of multiple aspects of value, such as, are you making my department efficient? Are you saving money? Are you creating some other value added services that is important to me as a CEO or COO of my particular hospital or business unit? And then one of the most important things that I have determined over the years, that's probably the most important and underserved thing that HTM departments don't do well, you have to communicate your department's value. At Methodist, we do that on a regular and annual basis. We let everyone know how our value compares to other sources, outsourcing companies, stuff of that nature. And we do that on a regular basis to make sure we're staying competitive and we're always staying on top of our game. So we're going to look at a couple different scenarios of what I call the HTM value shift. So looking at how we can move from certain activities that we're doing today to higher value activities that we can be doing tomorrow with proper planning and stuff of that nature. So one of the things that I early on decided to move away from is the sourcing of biomed parts internally. That has been a process we've outsourced for quite some time because it is a very low value added activity. And we moved to how can we insource things and drive service contract reduction and basically insource general biomed or specialized biomed equipment. We also looked at depot repairs and moving depot repairs, things that you normally can throw in a box and send off somewhere to get repaired. Instead of you trying to repair it at the hospital level, you ship it off and take those same resources and look at something like imaging service. And how can I insource either low-end imaging or even move into high-end imaging if you believe you have the skills and capacity to do so. A recent one that I've been evaluating and one I've actually done to some degree is infusion pump PMs, outsourcing those. There are plenty of good companies out there that can do that. But then moving that to something as radical as surgical instrument service, bringing that in-house and looking at the cost savings associated with that. And then we'll also look at database management. This is a brand new one that I've been looking at over the last couple months. There's some new companies out that can manage your data and do that for a fraction of the FTE cost that you may be doing today. And moving into more of life cycle management, how can you shift from devices you have today that are costing you more money to maintain or support and move to a lower cost solution or device to drive additional value, and putting HTM resources to work with supply chain in those efforts. So when we're looking at biomed labor, the typical BMET, including like salary, training, benefits, and other indirect costs, overhead, your typical biomed equipment repair technician is going to cost you on average an average of about $50 an hour. So the real question is how do you make that $50 an hour produce the greatest value to your organization or return on investment? And we're going to be going through some scenarios to kind of explain some of the methodology that I have used to kind of identify those opportunities. And this thinking can be utilized towards any different scenario by comparing two competing efforts to see which has the greatest value for your organization. So the first scenario we'll start with is the part sourcing scenario that we talked about earlier. So let's take a BMET III who is working on a Fresenius Dialysis Machine, and he spends 2 hours to find a third-party alternative to a flow pump drive. And after getting them to become an approved vendor, because they weren't an approved vendor before, it takes an additional 2 hours of that person's time. Now, in my organization, that's a pretty quick turnaround time to get a vendor approved. But we're going to go with 2 hours. Maybe this healthcare systems process is a little smoother than mine is. So the third-party pump cost after he has sourced it was $315. Hourly rate is $50 an hour, as we discussed earlier. He took a total of 4 hours of sourcing and getting the approved vendor status for a total labor cost of $200. This created a grand total cost of $515. Well, if you're a part source pro contract customer, that price is $330 on the pro portal. Notice that the price difference is only $15 for his 4 hours of total labor spent for this part. He produced basically a negative ROI of $185 or $46.25 per hour. This meant he or she would have had to purchase this part 13 more times to break even and actually save money. And that's even if the quality, even if there's like a quality issue, it could be less, because if you had to deal with additional issues with a third-party vendor because maybe they haven't been properly vetted or stuff of that nature, your cost could go up even longer, and it could take more times to break even in that cost-saving effort, if that's all the hours that you spent going forward. So let's transfer that time to another effort. So early on in my organization, anesthesia was one of the first things that we looked at to insourcing. I was able to find a great resource. So we're going to look at a Draeger Apollo Anesthesia Machine that has a monitor, it has a leak, and it's not reading end-tidal CO2 properly. Found that the unit had a bad O-ring, part was in stock, installed, and it corrected the problem. So the technician performed a verification test for 2 hours just to verify operation, make sure everything was running perfectly, and vetted that accordingly. So O-ring cost $7, going to be the same cost with Draeger, no major change there. Took 2 hours of your technician's time, total labor cost of $100 with a grand total of $107. Draeger hourly rate, I don't know if it's currently still this, because I haven't brought Draeger in a while, but it was $225 when we did this. And they have a minimum charge, or at least they did for us, 2 hours of labor and 1 hour of travel. That brings you a total labor cost of $675 with Draeger under a time and materials scenario for a grand total of $680. As you can see, there's not an opportunity to really source a part in this scenario, so the service is mostly labor. Gives you a positive ROI of $575 or an hourly ROI of $288 per hour. So the labor really had a huge impact on this ROI to cause it to become positive for the internal scenario. So this was a good trade-off from a sourcing effort to a insourcing effort of the anesthesia machine. And like I said, one of the things I did early on in my insourcing efforts in 2003. The next one we're going to look at is depot repair. And of course, this is a big area that covers multiple types of equipment, multiple manufacturers, models, and stuff of that nature. And that area continues to grow as both OEMs and third parties create more and more value in this space. But let's take an MMS module from Philips and look at some of the costs associated with that. So the internal cost, of doing this, you're able to determine that you have a bad NIBP pump. You ordered that pump from Philips, replaced it, and the testing took about 2 hours of burning it in, making sure that the repair was going to hold and that there were no other issues associated with the repair or service needed. So as we look at this, the pump cost was $675 with 2 hours of labor for a grand total cost of $775 if you did this internally. And if you sent this into PartSource under a pro, and I actually think this cost has gone down since I've created this presentation a year or so ago, but let's go with the old number of $450 an hour. Notice that this item can be sent in for repair and usually has it has an extremely negative ROI of $325 and an hourly ROI negative of $163. And the reason why that is repair depots can purchase parts in bulk from overseas suppliers, from buying used equipment and parting it out. And they can also repair, some depots can repair at the component level, which keep costs down. They also work off what I call the Henry Ford model, which is they are basically pushing things through the same like equipment over and over again, and they get really efficient and really good at doing these type repairs, which bring costs down. They can still make a margin, but they can offer it at a much lower rate than you can do it yourself. So this is a good area of opportunity. And I will kind of talk about that a little bit more in this next slide as well. So you can kind of see there's some other value adds to an outsourced depot scenario that I sometimes aren't able to include in these slides, but the things that are sometimes included is your shipping costs are sometimes included in depots that you send this stuff to. You don't have to source parts. You don't have a labor cost. And you don't have any OEM parts cost associated with this if it's a totally inclusive repair. The greatest value that I think a lot of HTM departments underestimate and don't equate into the depot scenario is the no hassle warranty, which depending on device type can be anywhere from 6 months to a year. So that means repeated failures, as long as you do a great job of tracking your warranties, are free. So that means that the value you obtain by getting that depot repair is even greater 6 months or a year after as well. It's like you're adding a service contract as you to your device for an extended period of time afterwards. So let's talk about what we can shift to that would have even a greater value to your organization. And we'll talk about imaging service. So early on, we did imaging. We started with low-end imaging, ultrasound, R&F, rad, what I call the low-risk areas. And so one of the ones that we evaluated early on for our cost shift was, we'll look at this scenario here of working on a GER&F ring that has a very poor image quality. And after your engineer works on it for 2 hours of troubleshooting, it is determined that it needs a pickup tube. You go ahead and you decide to source the pickup tube and order it. And because your engineer is not as familiar as, let's say, a GE engineer, it takes them 6 hours to install and calibrate this pickup tube. A little bit longer, let's say 2 hours longer than the GE engineer. Let's give the GE engineer a little more credit for having a lot more experience. And still, let's take a look and see what the ROI would be on this scenario. So the source tube cost was $8,000. GE is going to hit you for a little bit more because they have a markup. You took 8 hours for a total labor cost and 1 hour of sourcing for a total labor cost of $450 and a grand total of $8,450. Your GE cost, which their hourly rate at the time of this publishing was $425 an hour. I think that has increased since then. Their total labor cost is $2,550 for a grand total of $14,550. As you can see, the positive ROI on this scenario is $6,100 on this one activity, or for the hourly ROI of $678. So a huge difference in the value that this effort was able to provide you. As we all know, due to the high vendor parts pricing and labor rates, imaging service insourcing creates very positive ROIs, and it's something that every HTM department should look at to continue to develop their department, but also to provide the greatest value to their organization. So, like I said earlier, another scenario that I've been looking into is Infusion Pump Annual PM maintenance. It's probably the largest category of preventative maintenance that any HTM department has to deal with. The pumps are hard to find, they're hard to locate. Spend a lot of labor hours doing that. So annually, my department in one of my hospitals has 1,250 infusion pumps, and I have some good technicians, but I will tell you that it'd be great if they could do a pump every quarter of an hour if they rack and stack and really maximize their time. So let's go with that number, even though that's probably a really good technician who's really multitasking and driving value for organization. We're going to use that number. So your internal cost, we're going to assume that none of the pumps have any issues, that you're just PMing the units. There's no PM failures. There's no cosmetic issues. So we're going to say we're just going to look at the PM side of this and say there's no parts cost associated with this scenario. So as I said before, we got 1,250 pumps at 625 hours. And that's about 4 months with one FTE. So doing this full time, no breaks, no nothing. And your labor, overhead, all your other costs associated with that we evaluated was about $31,250 for a four-month period of time. I was actually able to price this out with a third party, and I've actually seen some lower rates recently of a per pump charge of $30 per pump to have your pumps PM'd. And the provider that I was looking at will even go out, they'll pick it up. You're not having to babysit them. It was a total turnkey solution. And only thing I had to do was collect the paperwork after they were done. And I noticed, you can notice that my total cost, if I outsourced this, was $37,500. Notice that even though this massive effort of labor produced a overall positive ROI of $6,250, the hourly ROI was extremely small at $10 an hour. So sometimes you got to look at your hourly ROI and see, does this make sense? Yeah, you may have a 4-month savings of $6,250, but maybe there's a better activity that would have produced a greater result. And so we're going to look at the next activity, and this next one's kind of radical, but it is something we have achieved at Methodist and has produced great results. So scenario 6, surgical instrument maintenance. And I know I'm not alone. I've heard of other organizations doing this as well. And I know a lot of HTM departments think this is not an area that they should be involved in, but that's how you continue to drive value in an organization, by looking at other ways to add value. That diversifies your portfolio of services and also makes it harder for you to potentially be outsourced if you have all these different avenues that you're creating value. So this is one we looked at, I think back in 2014. And in 2014, we were spending $500,000 annually on surgical instrument maintenance at all of our facilities. So we're going to look at the 4-month scenario of what those costs would be for internal costs associated if you brought that in-house. And so in this scenario, there will be some parts associated with it. There are some screws and some other things that you have to buy to maintain these instruments, some sharpening tools, some other supplies associated with it. And we estimated that to be about $12,000 a month on average, $12,000 for a 4-month period of time on average. Not a lot of parts expense, but there is some parts expense associated with this. So with your 625 hours of total labor for a 4-month period of time for that one FTE, same cost as before, you have a slightly higher grand total cost with the parts added of $43,250. The third-party instrument repair vendor for 4 months of spend on contract was $166,000 and some change. Notice that we achieved a positive ROI in that same 4-month period of time that we did earlier of $123,000 and some change, and a higher hourly month ROI of $197.47. So as you can see, the instrument repair was a much better use of 4 months of FTE's time and produced an extremely high ROI, both hourly and over that 4-month period of time compared to the previous effort. So I will tell you, this is a new one that I'm evaluating now. I haven't quite pulled the trigger on this one because I do spend a lot of time evaluating all my costs associated with activities, and just to make sure that I truly can walk away from an activity, that I'm not leaving anything behind that still be a responsibility of mine. But I'm going to give you the scenario anyway, just because I think it leads into the next scenario that HTM departments don't typically get involved in, which is life cycle management. So most organizations have at least an FTE that manages a CMMS system to ensure that their data stays clean, make sure that as devices are getting checked in, that they're getting checked in at the proper model. But they also have to run reports. They have to help with generating PMs and other activities if you want to truly advance an efficient CMMS system that helps drive performance with your engineers in the field. An annual FTE, like I said, fully loaded, overhead, benefits, all those costs for me is about $104,000 a year. I know that sounds like a lot, but you have to look at all the benefits associated with that FTE, along with the overhead of an FTE in your organization, and not just your hourly rate associated with that. So I've looked at this outsourcing database management company, and if it develops as I suspect, which is a true turnkey solution, I will only spend about $60,000 in a contract for a portion of an FTE and a system that's much more efficient than I have today, and a company that's developed a process for normalizing all my data on a consistent basis and do it that way. So if you look at it from this perspective, right off the bat, I have a negative ROI for that annual year of $44,000 or $21.15 an hour in negative ROI with this effort compared to an external cost scenario. So let's say I transferred that FD and I said, you know what, we're gonna work on a project of potentially changing the equipment that we have in our organization, such as moving from one device to another, either to help reduce like disposable cost and or maintenance cost of where we currently are today. And so today we interact quite a bit at Methodist with supply chain management. I'm actually part of supply chain. I roll up to them. And a lot of my duties today have to do with these type of scenarios here, along with some of my team members who help me evaluate these type of scenarios. So previously, we had kind of this bucket spread out over 3 vendors. We had our SCDs with Coviden. We had the old Express, a very high failure item in the SCD space, very small unit, prone to being dropped, also prone to some electronic issues. We had our fluid management, waste management system in the OR from Stryker with the Neptune device. As many of you may have experienced or are aware, Stryker aggressively tries to maintain control of their service, and recently made it harder and harder for in-house groups to maintain Neptune units. And then our Tourniquet solution was with Zimmer, and of course, from time to time, you have to do service on those as well. So we basically dedicated an FTE to kind of help work on this. And that didn't take them the full year, but let's say it took them the full year in this scenario to evaluate all the different scenarios and see what was available, negotiate contracts, go through this effort. So Our current disposable spend for SCDs was about $250,000. Now, some of you may ask, well, why do I care? Well, you should care, because part of your working with these other departments is you got to understand what costs impact them, as well as they need to be trying to understand the costs that impact directly the clinical engineering department or the technology management that occurs within the solution. So you need to be cognizant of that and make sure that you understand that the objective is to get the greatest value. And sometimes that may not always benefit the HTM department, but it may benefit the organization at large. And as long as you can explain the rationale, then there's an understanding of why your costs may be higher or whatnot. So in this scenario, that's what we were paying before, was $250,000 in disposables. As I said before, due to the high failure rate on the Coviden Express, we were spending about $30,000 a year in cost. The Neptune disposals was $650,000 a year, and the Neptune service, we had been pushed out of that space because of the restrictions Stryker had put on us to insource it. So we had went back on contract at $132,000. We thought we negotiated a pretty aggressive contract at the time, but we were always looking for opportunities to improve those outsourcing solutions to an insourcing option. Tourniquet disposables was about $23,000 a year, and tourniquets on average don't really break all that much. So we only realized about $750 in cost associated with a tourniquet or so failing during that annual period. This produces a total cost to the organization of $1,085,000 in annual expense. So after doing a lot of work and digging and doing some research, utilizing tools such as USRI for evaluation and working with our GPO or group purchasing organization to see what we could do around reducing our disposable cost and doing a really good job in negotiations, we were able to reduce our SCD disposable cost by 10% by consolidating all of this work under one vendor, which ended up being Zimmer. They had all three of these categories, and they were willing to bundle it together and give us discounts across most of the portfolio of disposables. But then we were able to also address some other service related costs as well. So when we first started talking to Zimmer about the SCD service, we were told, yeah, we can sell you parts and stuff of this nature. But what we quickly realized is that we wanted to be completely out of that business. We didn't really want to spend resources on something that would be considered a depot repair. And we negotiated a 5-year no-cost repair. And we negotiated it in such a way that any repair, even accidental breakage, was covered under that no-cost repair contract. And yeah, that took a lot of negotiations, but it took engagement from us saying, hey, this is an additional $30,000 a year that we can pick up if we leverage the disposable spend to gain some service cost reductions as well. We basically moved to the door knock or IntelliCart disposables, which from Zimmer, which saves as again 10% savings in the consolidation, which moved us to $585,000 a year versus the $650,000. And we were able to insource the IntelliCart service. The PM kits were less. We evaluated that. We were able to easily do the PMs on those with just some minor insourcing service of getting trained internally, which reduced our cost down to $64,000 in that space. Now in the tourniquet space, we didn't really gain much there. They already had that, so they didn't give us a 10% haircut on those disposables, and we ended up keeping our service cost at $750 for a grand total cost of $897,750 in total cost to the organization versus the $1,085,000 we had prior. So that produced over that annual period of time a positive ROI of $188,000 or $90.38 an hour. So a much better use of time. And I will tell you, if you're not in this space today, you should get in this space. There's many opportunities to move from very costly devices to maintain to lower cost devices. We spend a lot of time in this space looking at lifecycle management, and I've been successful in driving a lot of costs out of my organization in these efforts. So as we've been talking about during this presentation, this effort, this activity of value shifting is really a process. It's a process that is circular, that kind of can produce additional resources over time if you continue to do certain things. So the very first thing you got to do in these activities is identify the low value activity that you're doing today that's eating up a lot of time, a lot of resources, and a lot of hours, and see if there's a higher value activity that would create greater value to your organization and produce greater value results. And most importantly, measure your results. Don't be honest and measure those results, and then communicating those savings to your organization. We do that on a regular basis, whether quarterly or even we do an annual business review that we send out to our CEOs and CFOs to communicate the value that we continue to provide. And we also talk about the activities that we would like to move into that we believe there's additional value that we can gain. And those are important things. You have to run your HTM department like a business. And all businesses have business plans for the future on how they grow their business, how they expand, and how they continue to provide value. And then what I've found is after you start producing this value for your organization, they will start helping you by providing you additional resources. When I took over my department in 2002, we had about 25 engineers and support personnel that worked for me in a very lean biomed department. And I will say we didn't have anything insourced at that time. We had everything from anesthesia outsourced, balloon pumps, even ventilators. We were really just a bread and butter general biomed department. And we have today, in 2020, moved to a department of over 70 engineers working in all kinds of different aspects of this value shift process. And we even have a saying that even our engineers know what their value is to the organization. And we say that that is their right to exist, that they produce a value. And that means that if someone were to come after those resources, we'd say, okay, if this resource goes away, you now will move to having to pay more to an outsourced company or a third party because you're shifting the value in the wrong direction. So this brings about a new shift in thinking. I've brought this up to my engineers multiple times, and it's something that we constantly reiterate, which is it's not whether you can repair a medical device that's really that important. Yeah, HTM engineers all want to be able to say, I'm a hero, I fixed a particular device. That's really not what you should be asking yourself. It's whether you should be the one repairing it. Evaluate your cost and ensure that your team is focused on the highest value activities for your organization. That will produce the greatest results and continue to provide you with sustained growth in the future as you look for these different opportunities. So with that, I'll turn it back over to Colleen for questions.
Thank you so much, Jeremy. So to all of our audience, at this time, you may submit your questions using the question section on your control panel. We will take the time to answer as many questions as we can today. If for some reason your question is not answered, we will answer that via email. So we'll give a few moments for questions to come through the queue. And actually, a couple were entered as we started here today. See what we've got here.
I see one, Colleen, coming through on the chat window, just inquiring about Jeremy's CMMS system and sort of his system landscape.
So today I'm currently with AIMS. I am eagerly awaiting AIMS III. There is a lot of advantages to the new platform. We do use our AIMS, our CMMS system, as our main driver of all data related to costs. So we order our parts through our CMMS system. We make sure all that rolls up to the devices, and that helps us identify those opportunities. We have people who constantly run reports to look for those value opportunities that we can take advantage of, and CMMS is the primary way we do that.
That's great.
Thanks, Jeremy. We have another one that says, how do you get customers, I guess they mean your departments, to move out of silos and get on board with your thought process?
So that's a very good question. I mean, early on in my career, I will say that there were, because of the multiple hospitals, there were separate biomed departments at Methodist Le Bonheur Healthcare at one point. And I think the key is if you can show that your operation is really, really running efficiently and you're being fully transparent in how you're operating and how you're continuing to drive value for your organization, then the organization will continue to look for ways to break down those silos. And you as a leader, it's your responsibility to go forth and throw out those ideas for how do we break down those silos and merge them in with your department. If you have a segmented department, like let's say your imaging service is separate from your biomed, or you have multiple hospitals and each of the hospitals has their own biomed, you can go about it from the standpoint of discussing how scale creates additional value and opportunities to create value for the organization. And that's what I did. We were very fragmented when I first took over in 2002. And probably over the course of about 5 years after I took over, we slowly continued to consolidate until we pretty much had one corporate clinical engineering department. By 2008, we were completely consolidated. And then we started breaking down either other additional silos like an SPD and other areas where we got engaged in areas where we felt we could add value to the organization. But we basically threw out the opportunities and the organization decided whether they would take advantage of those opportunities. And a lot of times they did, and sometimes they didn't. And sometimes they said, just not right now, but maybe later. And so I think you have to take the approach that you don't need to give up and you need to keep trying to find ways to do that. Okay.
Thank you. You see one, Dave?
Yeah, so there's one here that I think is really pertinent in terms of training costs, and I suspect the training as it pertains to taking on the next kind of modality or next kind of device, Jeremy.
Well, that's extremely important. I've always said training is the lifeblood of a healthcare technology management department. What we do at Methodist is we are allocated money from the hospitals. We are treated as a profit loss center. Now, what that means from my perspective and how we run it is that I get handed a bucket of money that I can do with based on the equipment that I support as I wish. So I can spend money on training, I can spend money on test equipment, whatever I think drives the greatest value and return on investment, I have the flexibility to do that with. So I've always said that HTM departments have to really get really good tight control over their budgets and how they manage their costs. And then also sell the organization on the fact that you have to be able to have flexibility in what you spend that money on. A lot of hospitals will come through and restrict things like, oh, we've got a travel ban. We're not traveling anymore because we're trying to reduce cost, or we're trying to do certain things. Those are very detrimental to HTM departments, and you have to communicate that's going to be detrimental. It's actually going to have the reverse effect of what the CFO or supply chain person would like for them to achieve by these mandates that happen across hospital systems. So you have to be very vocal about that and move to that more to that type of mentality.
For sure. There's another one in here that I think is really pertinent, which is about the order of attack. Right? Where do you go first, particularly in imaging? How do you begin to insource imaging? And then there's a follow-up question about detector panels and whether or not you pool them or not. But I think the first one is, what's the order of attack?
So I can talk about my order and where I made pitfalls and along the way. The ones I went after first were what I call the easy ones: ultrasound, portable X-ray, C-arms were my first three right out the gate in 2004. I will tell you, I didn't save a whole bunch in portable X-ray. I didn't realize at the time that if you have a big CompuCare agreement or something like that with an OEM, that they'll pretty much give away those type services. Where I had the big savings and where I had the biggest value was ultrasound and the managing of the probes and the PMs and services associated with those units. We then went quickly into R&F and rad rooms after that, about a year or so later. And then we moved into one of my pitfalls, which I didn't do a good job of kind of vetting, and kind of had a couple stumbles along the way. I still saved money, just didn't save what I thought I would, which was Nuke Med. Moved into that. Didn't realize that that was less of a parts business and more of a expertise business. And that's the kind of stuff you have to evaluate over time. And then we moved into, in 2008, we basically decided, and I wouldn't recommend this to anybody, but we were challenged with taking everything else that was left with the exception of digital mammo. So we went after MR, CT, cath and vascular and interventional radiology, and all those systems in 2008, and took the remainder of the CompuCare agreement away from GE at the time and brought all that stuff in-house. And that did create a very challenging year. I had to spend a lot of time and money and resources hiring expertise and relying heavily on third parties for assistance early on in the process. In the matter of detectors, I am big on creating pools, but I create pools that I control. So I usually don't sign up for insurance programs or stuff of that nature, whether it's detectors or tubes, stuff of that nature. I early on learned to steer clear of those. And that's primarily because you can carry the risk just as easily as somebody else can. And the problem is a company that's carrying the risk is going to overestimate their actual cost spread over time, which means you're going to pay for services and things that you probably don't fully utilize. So I've always taken the risk completely on our department, and in that nature of being a profit loss center.
Excellent. Here's another one. Actually, there are two related. I think people are impressed by the database management costs you showed. So they're wondering, about those costs. Who are you using for your database management? Has come in more than once.
Yeah.
So I don't know if you want to elaborate on that.
Well, so keep in mind, this is not replacing your CMS system. This is really having, and again, I haven't fully vetted this, but there's some new companies out there that will literally manage your data in your system for you. So that's what I'm working through now. There's a company called Genesis that I've been looking at. Again, I haven't fully vetted them, but if it bears out, that's where we would potentially look at going to, or a similar company if we can find other competitors in that space. So it's not moving from your CMS system to another CMS system. It is basically saying, hey, how can I outsource the management of the inputs and outputs of that system?
That makes sense. Here's another one that relates to your ROI calculations, Jeremy, and it's really wondering about how you factor in downtime or revenue loss, and do you ever include that kind of math in your ROI calculations?
So technically no, and there's a couple reasons why I do not, because that basically assumes that there will be more downtime with an in-house solution than an external solution. And I have not agreed with that. If anything, I believe an in-house group will have less downtime than the exterior resource. And the reason I say that is A, you're on site. That means you're quicker. You're going to be there usually an hour or so before an outside resource would be there. Second, most in-house groups, and I experienced this, and I feel confident I can say this almost about every OEM that I've come behind, in-house groups do a much better job of doing preventative measures which improve uptime and lengthen the mean time between failures. And that's one of the things that we did early on, is basically get to a more proactive approach to maintenance around all medical equipment, but really primarily imaging. We got into the effort of failure prevention, which drove our uptime up drastically. We typically run a 99.5% uptime or greater in our organization because of those factors. And I'm always challenging my team to figure out even better ways of doing that through preventative measures. And we're even installing some power monitors and power conditioners to even drive the failure rates down even lower. So that's some of the things that's why I don't really take into account downtime, because it goes with the false assumption that an in-house group is going to have greater downtime than an exterior source, and I don't buy into that at all.
That's great. There's another one here, Jeremy, that's really about the cost of your internal labor. The question is centered around what is the cost of your internal team versus your total budget? What proportion does that represent effectively?
Very, very good question. And that's actually something I had analyzed years ago. And I kind of have to break it down into two buckets, because we actually break our division into cost centers that are separate. So I'll kind of break it into that format. So in our general biomed cost center, the labor to parts and services ratio is about 1/3 labor, 2/3 parts and services. In the imaging engineering cost center, it's about 1/5 labor, 4/5 cost and services in that scenario. So that's what I've typically seen, and I've seen some variations of that. I've seen it as high as a 50-50 split in biomed, and from other organizations that I've done consulting work for. But what numbers usually work for me is about 1/3, 2/3 on biomed, and 4/5, 1/5 labor in the imaging space.
That's great. There's another one here about cybersecurity. Interesting. We were just talking about cybersecurity, and about how you see cybersecurity of your medical devices impacting your bottom line. Is it something you measure?
So we started our cybersecurity journey, and for us, we manage our own cybersecurity within clinical engineering at Methodist. We have a team of, it's actually another separate cost center. It's the integration and cybersecurity team, which is a combination of biomeds and IT folks that report to clinical engineering. And we use a tool, and there's other tools, plenty of tools out there, but I use a tool called Assembly. And it basically provides me all the intel that I need on how should I remediate my medical devices. And so far, other than adding some costs that I didn't have prior, I haven't seen it affect my bottom line all that much. If anything, it is a tool that is almost a cost doing business now. If you don't have some kind of medical device cybersecurity tool, you're probably behind the times. It is really important, because anything that happens on your network that's related to a security threat or a data breach is going to cost you phenomenally more than any cost associated with those efforts. And that's how we were able to justify it, and that's justified kind of separately from some of my other metrics that I utilize to measure production. But that same value effort or measurement still occurs. What's the cost of a data breach? And you hear about them all the time, and there are millions of dollars associated with that. And medical devices, although rare, can be used as pivot points to access the network. And so having good strategies around that is extremely important. And we spent quite some time with the help of Assembly developing those on a device-by-device basis, and really understanding how that's different than just your normal maintenance, or how it's different than how IT addresses cybersecurity with their devices.
That's great. I know we're almost up on time, so I'll give you one real quick one here, Jeremy, at the end. It's somebody who's wondering about how much data you share with partners. Do you trust? Do you sign NDAs? Do you share data with partners outside of Methodist?
That is a very good question. I have done that in the past. I've done both consulting relationships and signed NDAs with certain organizations. I also have them sign NDAs with me / Methodist for those efforts. And so we do share information. We typically, when we do an engagement like that, we offer an initial consulting based on what question or effort you're trying to get to. And then we usually offer some consulting services after the fact to help you navigate through some of the pitfalls that may occur during those processes. So yes, we have done that in the past.
That's great.
All right. Well, thank you, Dave, for helping tee up the questions there for me. And thank you, Jeremy, for your time presenting and all this great information you've shared with us today. And also thanks attendees for joining us in your time today. As a reminder to all of our guests, you will receive a follow-up email with a link to the recording for today's presentation. That'll come in 2 to 3 business days via email. Be sure you join us next Thursday for the next installment of the HTM Leadership Series, Decision Support, Procurement. You get quality when you ask for it, which will be presented by Carol Davis Smith, the president of Carol Davis Smith and Associates. At this time, the webcast is ended. Thank you for attending and have a wonderful day.